This week on the BackTable Podcast.
We just are kind of right now finishing a study where we're kind of just interviewing patients and seeing where are things falling apart, where are you kind of getting lost in this flow, and even trying to identify where this is happening. But I think a lot of it is going to be education, community outreach, trying to kind of better educate these patients, the PCPs that treat them, and get more information out there so that they can get treated if they have OSA, because they deserve to get that identified, diagnosed, and treated appropriately.
Hello, everyone, and welcome to the BackTable ENT Podcast, where we discuss all things ENT. We bring you the best and brightest in our field with the hope that you can take something from our show to your practice. Now, a quick word from our sponsor. For over a quarter of a century, Medtronic ENT has been at the vanguard cultivating hands-on advancement for ENT professionals. From the precision of PTI aiding in parathyroid detection to the cutting-edge drug delivery of Propel implants and the accuracy of their navigation systems, Medtronic integrates high-level technologies into one seamless surgical experience. Dive into the latest ENT innovations with their live events, webinars, and the visiting clinician programs. Engage in live surgeries, faculty-led discussions, and exchange best practices in their state-of-the-art training labs. Their mobile labs and unlimited Medtronic Academy e-learning content, including procedural animation, deliver the future of ENT care directly to your fingertips. Visit medtronicent.com. Now, back to the show. My name is Gopi Shah. I'm a pediatric ENT, and I have an awesome guest today. I have Dr. Megan Durr. She's an associate professor of otolaryngology, head and neck surgery at the University of California, San Francisco, and is the chief of otolaryngology at the Zuckerberg San Francisco General Hospital. She specializes in surgery for sleep apnea and snoring. Dr. Durr is here to talk to us about obstructive sleep apnea in women. Welcome to the show, Megan. How are you?
I'm great. Thank you so much for the introduction, Gopi. And I am an avid listener to this podcast, so I couldn't be happier to be here. It's my favorite thing on my commute. So,
well, I'm so happy to have you guys. Like, I say you guys because as I was just saying, we were talking ahead before we started recording, is you guys have such an amazing team at UCSF. We've had Patricia Loftus talk about nasal polyps. Sarah Snyder came on to talk about gender-affirming voice care. And then we had the dynamic duo, Dr. Daniel Knott and Dr. Rahul Seth talk to us about gender-affirming care, advocacy, education, facial masculinization. So it's been so great to have so many of your faculty and team from UCSF contribute and share their knowledge. But I want you to tell us about yourself and your practice today. So tell us a little bit about yourself and your practice.
Yeah, absolutely. Happy to. So I guess starting from the beginning, I grew up mostly in the Midwest, mostly Indiana area, and I went to Purdue University. I studied engineering there, kind of always knew I wanted to go into medicine, and given my interest in kind of working with my hands and problem solving, knew that I would likely be interested in a surgical field. So I went to medical school at Johns Hopkins, decided to obviously apply in otolaryngology, and I did residency at UCSF, where I'm at currently. When I was in residency, I spent actually a lot of time doing sleep surgery. One of my main mentors during residency was Dr. Eric Kazarian, who is a well-known sleep apnea surgeon and was a huge inspiration and mentor to me. So when I left residency and joined practice, I joined as a general otolaryngologist at Kaiser Permanente in Oakland. There was just a huge need for someone to do sleep apnea surgery. I knew I loved it. I knew I wanted to do it, but I did not expect for it to be such a passion of mine in the future, and as become. So I got into practice at Kaiser Permanente. The person who was doing a lot of sleep surgery there was entering retirement and looking to kind of back down on OR. So I had all these patients that I was seeing and really got the opportunity to learn some of the skills that I had developed during residency, and slowly developed a sleep surgery program at Kaiser Permanente. I again was based in Oakland, and the timing was actually kind of perfect because right after I started, the FDA approved the Inspire hypoglossal nerve stimulator implant. So then I was able to get that approved, and we were the first site within Kaiser to be placing the Inspire implant for many years. It has since grown, and so I'm excited that after developing that program, it has expanded to all the different Kaiser areas, Colorado, Pacific Northwest. Southern California is doing it now. And so slowly grew into quite the Inspire program. So it was really great. And I did develop a passion for sleep surgery. And then in 2022, I transitioned to UCSF. And I am here now doing sleep surgery. And as you mentioned, I'm also the chief at the Zuckerberg San Francisco General Hospital, which is a safety
Congratulations.
Thank you. Yeah. As I told you, I just kind of formally, I was interim when I started, and just within the past couple of weeks formally took on the position, which is exciting. So I appreciate your congrats.
Yeah, that's awesome. So in terms of sleep apnea in women, is that something, did you notice that there may be a difference between men and women? Like, was this something that you noticed early on, like in your residency from your mentor, or once you started practicing?
Yeah. So interesting question. It was not something I really thought about. And I feel like at first kind of came on my radar when I was pregnant. So I have 3 young kids, 5, 4, and 1. And so I've been pregnant a lot the past 5-6 years, as have a lot of my friends. And everyone knew I did a lot of sleep apnea surgery and had an interest in sleep apnea and snoring. So many of my friends, when they were pregnant, would come to me and say, Megan, I am snoring. It is horrible. I'm waking myself up. My bed partner can't sleep in the same room. I'm exhausted. And this was happening fairly regularly to the point where I was like, what is going on? Is this just my friends or something? Because so I started looking into it. And I would also say, I also had a lot of colleagues, friends, and patients kind of going through menopause. And I noticed that during that time also, it was a tough time for sleep. I mean, I think on top of the hot flashes and everything that comes with menopause, people certainly do develop other sleep disorders, including sleep apnea around this time, which got me really thinking, is this something different? And why are we not really talking about this or thinking about it? It was also interesting that I started to notice that a lot of my patients were men too. And I was wondering kind of what happened. Where are the women going? They're clearly struggling. So they're coming to me out in the community, just asking, friends and colleagues asking me, but I'm not seeing as many women in clinic. And I think the same goes for kind of underrepresented minorities too. I would say in my practice, the majority, not all, but the majority of people that I see were men, middle-aged, white, fairly health literate. And it made me kind of get more interested in where are the other people going? They clearly have sleep apnea. Why are they not making it to this point where they're looking into sleep surgery? And that led into some research interests of mine, including kind of women and underrepresented minorities and barriers to care for sleep apnea.
No, I think that's great, because I feel like I used to always think of it more as a, higher incidence in men. And so when we were corresponding, I'm like, hey, let's do this podcast. I'm like, oh, I was seeing women, like I didn't even think about it. So to me, it's very new. So have you found, like, are we just missing women? Are the symptoms different? Are they not being referred? Do we know the true incidence?
Yeah. So I think probably all of these things. And kind of the interesting thing is there is not a lot of literature on this topic, which is kind of crazy to think about. I mean, when we're talking underrepresented minorities and all women, this is a large portion of our population that we just kind of don't really know. But there is some information. So I would say getting at missed diagnosis, almost certainly, I think the data is pretty clear that we are missing a lot of people with sleep apnea, but women probably are disproportionately being impacted by this misdiagnosis. And I think it's some of the reasons, and many of which you mentioned. One is symptoms. So women, I think I used to think of sleep apnea symptoms as coming in with snoring, falling asleep during the day, super tired, bed partner, witnessing apneas, choking, gasping at night. And this is actually not what women usually present with. This is kind of more typical of a male presentation. And so I think when people go to their PCP with those symptoms, which is usually the men, they're more alerted to, hey, let's get a sleep study. And so women, in contrast, present more with like mental fogginess, memory issues, fragmented sleep, insomnia. And those are kind of more vague symptoms. So I think a lot of times they come in, and it's usually to the PCP at this point, right? Saying these things, and they're thinking more like anxiety, depression, hypothyroid, and kind of sleep apnea is not necessarily the first thing that jumps out to them. So I think that's kind of one huge area that's causing us to miss women. I think another thing is these screening questionnaires that we do. So like the stop bang is probably the most common one that we know about, used by anesthesiologists primarily when people are in a kind of perioperative clinic getting evaluated. And so those are screening for male symptoms, right? So if you think about stop bang, they're mostly looking at kind of sleepiness. So S is sleepiness and tiredness, or S is snoring, T is tiredness, O is witnessed obstruction, choking, gasping, all these things we talked about that males present with. So there's not much data on this, but I have to believe that using these questionnaires that assess mostly these obstructive symptoms, these sleepiness symptoms, are missing a lot of women, and they're just not getting alerted to the fact that this might be obstructive sleep apnea.
Are any stop bang, Epworth sleepiness, like any of these sleep surveys, are they validated separately based on sex or gender?
No. And so I think that is huge. It's something I'm interested in looking at. Do we need to either validate these women, or do we need like a totally different survey that asks for some of these more atypical or vague symptoms that women present with? Because I think if we looked, I would have to guess that, again, we're missing women when we use these specific symptom scores.
Yeah. And it's funny, you mentioned men coming to your office or, I think of the primary care office, whether, general ENT clinic, and, maybe I'm more inclined as a physician too to ask the male patients about sleep apnea, because I assume that maybe, the woman who's may not be as high risk, I just maybe have a inherent bias because I just see it more in men too. Like, I don't know. Do you think that might play a role too, and just in terms of what we're looking for?
Yeah, I think that's absolutely true. I think we all, when we think of sleep apnea, think of like an overweight middle-aged man, unfortunately, is kind of what comes to mind, and is probably in all the textbooks. But that does not mean that women don't suffer from this. So the studies do show that is more common. I mean, it certainly is more common in men than women, but there are a lot of women that certainly suffer from this. When you look at, so they've done these big epidemiological kind of longitudinal population studies, like Wisconsin Sleep Cohort or Sleep Heart Health Study, where they just follow people for a long time, give them sleep studies, see who develops sleep apnea, see what the natural history of their sleep apnea is. Those show that it's like a 2 to 3 to 1 ratio. So certainly more common in men. So men, like 2 to 3 men per 1 women will have sleep apnea. And so certainly more common in men, but not to be discounted in women. Interestingly, when we look clinically, so when patients actually come to their PCP and get diagnosed, that's the studies show more like an 8 to 1 men to women ratio. And so when we just screen women without asking about symptoms, just, across the board screen them, we're finding that it actually is more common in women than when we're relying on our current screening and testing mechanisms clinically, which is also kind of interesting, I think.
Yeah. So you'd mentioned some of the symptoms like mental fogginess, insomnia, foggy memory, there. I think about that because I'm like, that could be just me being, middle-aged mom of 2, like trying to keep up, right? Like that, and that's just not a normal symptom. Like, and you're right, there's so many different things that can be going on or can be happening. So, when you do have somebody in your clinic, or maybe by the time they see you, maybe they've already had a sleep study. But I feel like that differential, and you kind of mentioned it could be so many different things. What is kind of in that differential, or that we need to add sleep apnea on that list of stuff?
Absolutely. Yeah. And so I think I'm a little bit lucky in that we mostly require that people come to my clinic have a sleep study. So I kind of get to look at that. Although we can talk about this, there are issues with the way sleep studies are graded that might not be as inclusive of women. So I think we also have to look carefully at the sleep studies to make sure that we are including women that have slightly different findings on sleep studies. But if I see, say I didn't have the sleep study, but if I see a woman who's explaining these types of symptoms, describing some sleep fragmentation, the mental fogginess, I will always recommend a sleep study and not just assume that this is insomnia or something else, because I think it's important that we also look for that and assess for that. Certainly, many of these people have comorbid insomnia and sleep apnea, but I think we should not just call it insomnia and move on, because we could very well be missing OSA, because, as we talked about, these women are presenting with some of these more atypical symptoms.
In terms of like long-term effects of OSA on women, is it similar as some of the long-term effects that we normally think of, potential, depending on how severe it is, even like right-sided heart failure? Does it present similar, or are we, I think of like coronary artery disease, and, now we're more aware about its risks in women. How does, in terms of long-term effects of long-term OSA on a woman, what are some of the risks or other complications, comorbidities can they develop?
Yeah, absolutely. And I love that you mentioned the cardiovascular comparison to this, because I think it is quite similar. We now know that women also present differently with heart attack and may miss heart attacks. And I think this is kind of a very similar scenario. So the long-term side effects for OSA, cardiovascular risk, diabetes, hypertension, even dementia, there are some emerging studies that show women probably have higher risk of some of the cardiovascular complications from OSA, which is very interesting. So that's congestive heart failure, even kind of mortality from congestive heart failure, hypertension, probably are more prevalent in women with OSA than men. And we don't really know why. I think this is really interesting and especially important because, like we talked about, we're missing the diagnosis in many of these women. And then we also know they're probably at more increased risk of some of these cardiovascular complications, which is scary. And I think it means we need to step it up and just do better assessing and screening and diagnosing these women so they can get the treatment that they deserve.
In terms of the referrals, do you find that a lot of referrals for women are from their GYN? I mean, a lot of women have one. They don't have a PCP and an OBGYN. They might just have one or the other. And I think of especially women under, younger women that are, you go to your GYN. You may not have a PCP until, into your 40s, potentially. You know what I mean? Like, so where do your referrals come from? Or, do you have these conversations with your OBGYN colleagues? Are they seeing this more and, sending this to you?
Yeah, that is a great question. And I think I could probably count on one hand the number of times I've gotten a referral from an OBGYN. It is almost always PCPs, neurology, sleep medicine. And I think this is a huge area that needs to be addressed. I just wrote this paper with one of our excellent residents at UCSF on pregnancy and menopause and OSA. And it really, in digging through all those papers, alerted to me that we are just, again, not doing a great job for these women, because I think, that we need to partner better with the OBGYNs, especially in identifying OSA in pregnant women. We know the rates go up like 3 times when you're looking at fertile women of fertile age for when they're not pregnant versus pregnant. It's like 3 times higher for obvious reasons. They're going to have more mucosal edema, weight changes, hormonal changes. And we know it dramatically affects the mom and the baby. So the studies show that moms have higher risk of preeclampsia, needing ICU stay, even maternal mortality when they have gestational OSA. And the babies, similarly, lower birth weight, congenital anomalies go up. Even we found some studies that showed long-term, they're more likely in the first year of life to require hospitalizations and more likely to have lower test scores once they become school age. So I don't know of any offices, and certainly there probably are some, but I don't know of any offices that are routinely screening for OSA in pregnancy. And the study shows about 15% of pregnant women will have OSA. And so I think it's certainly important to screen for. And I have seen pregnant women coming in, and it is a problem. I think diagnosing sleep apnea and getting the treatment, which universally is CPAP to start with, takes a long time. So even home sleep studies can take a couple months. Then you have to get your DME approved and get the CPAP sent and try different masks. And we're talking months and months here.
The different masks might change.
I know.
And your mask might change second trimester to third trimester.
Absolutely. It's very true. And so I think there needs to be a better system here to, one, identify these women quickly and get expedited sleep studies, expedited CPAP to help improve the risk, like we talked about, for mom and baby, that we are just not doing now. And it's been really, I've had some patients that really are struggling, and maybe they'll finally get the sleep study, but it's like they're 35 weeks and there's no time to get the CPAP and get things to, obviously we're not doing surgery in pregnancy. So CPAP and mandibular advancement device similarly take a couple months to fit. So we're looking at CPAP and probably needing to find a system-wide way to get that expedited for these women.
So you said that the incidence goes up about 3 times during pregnancy. In menopause, do we know the risk?
Yeah, so I'm glad you asked that because this is actually what kind of got me interested in this topic to begin with. So we know that in you're a pediatric otolaryngologist, so you know, in kids, it's pretty similar rates between girls and boys. But
well, I was going to ask you, does it switch during puberty or adolescence? And as a peds ENT, do I need to think about, because I feel like under 12, okay, fine. But once, or not even, maybe I shouldn't even use the age. Pre-puberty, fine, it's similar. But post-puberty, even when I think about sleep studies, I'm like, should we be grading an AHI of 8 or 9 as, mild? Or is this really, almost severe now because the kid is, 15, but has gone through puberty? You know what I mean? Like, how do we want to really grade that and treat that? Or does that, so anyway, so I think of it from that standpoint. But when you bring it up in terms of, girls and boys and hormone changes and development and puberty, there's probably a change during that time too, maybe. I don't know.
Yeah, I feel like I do not know of any studies looking at that, but it probably is when it changes because the thought is that there's a hormonal effect. We know in childhood, the rates are about the same between the different sexes. And then at some point in there, probably puberty, but in mid-age, it's much more common for men to have OSA than women. And then interestingly, as we hit menopause, the rates become equal after menopause. So the thought there is that probably several things, but one is almost certainly there's some hormonal component to this in that we know estrogen and progesterone are stimulators of respiratory drive. They help kind of stabilize the airway. So as those drop when women go through menopause, they are likely having higher risks of OSA. There also are some fat distribution changes that can be protective of women in premenopause period. So women tend to have more of that gynoid fat distribution more in the hips as opposed to men that are upper body fat, and that's going to predispose them more to OSA. That can change at menopause. So that's probably part of it, the weight gain and change of fat distribution. I think almost certainly there is a hormonal component to this that is protective for women before menopause.
In terms of the patients who may be on hormone replacement therapy for, whether for gender affirming care, for example, how does that affect their incidence of OSA, or have you seen a pattern?
Yeah, it is, there is not much literature on this at all. It is interesting. And I've thought about looking into it and probably should. All I know of is just like small case reports, case series that do show. So the case series that I'm familiar with had 3 patients. So one was a transgender man, so at birth assigned women, and then transitioned with female hormones, who then resolution of OSA, had diagnosed OSA pre-transition, and then it resolved after starting female hormones. And then 2 transgender men who at birth assigned female and then started male hormones, and then developed OSA when they had a sleep study showing no OSA. So it's interesting and probably is impactful for these patients. There are some studies on women, so premenopausal women that undergo surgically induced menopause, and those women have higher rates of OSA after surgery than premenopausal women who don't have this surgery. The studies on hormone replacement therapy with menopause are pretty variable, though there are some that show if you're postmenopausal and take hormone replacement therapy, you may have decreased risk of OSA. Although that the jury's maybe still a little bit out, those studies vary, but there is almost certainly a hormonal component. And I think the studies are a little bit hard because every study uses a slightly different hormone at slightly different doses. And so we see a lot of variability. But my assessment of these studies is that there has to be some effect, and maybe more than we even know.
Yeah. Tell me about your physical exam. What are the differences on, physical exam? What are you looking for, the patient that's a woman versus the patient that's a man?
Yeah, I pretty much do the same physical exam regardless, in that we do very thorough head and neck exam. I measure neck circumference, which it's generally, as we talked about with fat distribution for women, generally less for women. Do a good nasal examination. That's a large part of sleep disordered breathing, CPAP tolerance. I'll do a good oral pharyngeal examination. I pretty much scope everyone that I see in clinic with OSA as well. And DICE is something that I will commonly perform if people are considering surgical intervention, especially if they're interested in learning about candidacy for hypoglossal nerve stimulator. We actually just submitted an abstract to Academy. We looked at UCSF, our sleep surgery group looked at our DICEs to see if there were different findings for women versus men. And we did find actually differences there, which is interesting. So women had less complete oral pharynx lateral wall obstruction when compared to men. That is also a finding that correlates with poorer success with Inspire. And so men are more likely to have that finding that we have since learned can cause less of a chance of having a successful hypoglossal nerve stimulator surgery, which is interesting. There are studies. There was a retrospective study looking at a multi-center study looking at DICE examinations on patients that had received Inspire and kind of compared the DICE findings to Inspire success rates. And they found that this lateral oral pharyngeal wall showed decreased success rates. There have also been studies showing that women tend to have higher success with hypoglossal nerve stimulation. So it's probably for multiple factors. We know women probably have a little more hypotonia based on this estrogen effect that hits them at menopause, and that they have less of this lateral wall obstruction that can be a negative predictive factor for success with hypoglossal nerve stimulation.
Do you use any MRI in your practice? Is that helpful in your preoperative evaluation?
I don't use that. I don't know of any centers that use it for adults. I'm sure there are. I think certainly drug-induced sleep endoscopy is much more commonly used for adults. And part of that is because it's currently required in the evaluation for hypoglossal nerve stimulation.
In terms of sleep studies, what have you noticed in terms of, variables, differences in, whether it's AHI or PCO2s or oxygen desaturation? Like, what variables do you look at now when you have a female patient in front of you and you're like, oh, okay, like, what are we seeing in terms of differences there?
Yeah. So this is also very interesting. I feel like I keep saying that.
But this is so great. It is very interesting.
So women in general have less severe OSA, tend to have lesser desaturations. And so oftentimes they will be kind of lower on the spectrum or even kind of borderline. And I think this is also an area where they can get overlooked. They say, oh, your AHI is 4.5. You're fine. Don't worry about it. So many things I look at is I will look at hypopneas. So women tend to have more hypopneas than apneas compared to men. Apneas are when someone stops breathing completely for 10 seconds. A hypopnea is kind of, for better or worse, the lesser version of that. They have decreased airflow by 30%, and it has to be associated with a desaturation. And so women tend to have more of those. Not to get into the weeds, but something I think is important to also consider when you look at sleep studies, especially for women, is how the hypopneas are graded. So there are primarily two ways to grade hypopneas. One is what CMS uses as their criteria, and that is you have to have this decrease in airflow plus a 4% desaturation. But the American Academy of Sleep Medicine, their definition is a 3% desaturation. And so there is also kind of emerging evidence that using that 3% desaturation rule is much more inclusive of women because they have fewer desaturations. And so I will also make sure to look to see what criteria is used specifically for hypopneas, because we're much more likely, again, to miss women's OSA, sleep disorder breathing, if we're using this 4% criteria. And this is another area where I think women get missed. And then if your sleep study shows that you're borderline or no apnea, then you're not going to get coverage for CPAP and some of the treatments that they really need to feel better. Whereas if they had that 3% definition, then they would be candidates for trying some of these things that they probably really need.
Yeah. So let's say we have, the 53-year-old female, has been in menopause for about 2 years now. That sort of mental fogginess and fatigue, maybe a little mouth breathing, nothing, not major snoring, in your clinic, let's say of normal weight, and let's say they have, AHI of like 7 to 8 an hour with, some more hypopneas and apneas and, some of those findings. What's next? How do you counsel that patient?
So certainly we recommend everyone try CPAP first. I strongly encourage people to try that. I will encourage them to try every possible mask. I'm a big proponent also of doing, you said mouth breathing, so a big proponent of doing anything we can to improve the nasal breathing, promote nasal breathing to help with CPAP tolerance. People tend to tolerate CPAP better when they wear the smaller nasal masks. So that is something I will always talk with patients about. I think especially these more mild OSA patients, that can be all it takes. They usually don't need as high of pressures on CPAP. And that's true for women in general compared to men. And therefore, if there's any little things we can do to help improve tolerance, they're probably going to do a little bit better with CPAP. Those are kind of some of the main things. If they cannot tolerate CPAP and have really given that a good try, we've tried different masks, then oral appliances, or studies showing that women are probably better candidates for oral appliances, generally probably because they have less severe OSAs. They don't have to pull it so much forward, that they tend to not carry their weight up in their neck and tongue area. And so the studies show they tend to do a little better with mandibular advancement devices or oral appliances for OSA. So that's something I will consider usually a second line if they failed CPAP. But for some people, if they have severe claustrophobia and are just not going to try CPAP, I have tried that first for patients.
Do you have a dentist that you work with who helps with the oral appliance?
Yes. Yeah. Our dental school at UCSF does a great job making these, and we're working closely with the patients to pick the correct appliance for them, which helps a lot. Just having that guidance and follow up afterwards and doing the adjustments can help a lot with tolerance. There are also many excellent private dentists in our area that specialize in this. And so we're lucky in the Bay Area that we have opportunities.
And then how do you follow that? Do you just have them get used to it and start wearing it every night for a couple months? And then you're like, okay, maybe we try another sleep study with the appliance on, or how does that work?
Exactly. I'll always recommend, once they're using it nightly and comfortable with it, a repeat sleep study to make sure.
With the device on?
Yep. Okay. Usually I just do home sleep studies at that point when we're comparing the pre and post to ensure that their oxygenation, apnea, hypopnea numbers have improved with it. The other thing I will look at, especially with mild OSA like this, is positional obstructive sleep apnea. And so I see that fairly commonly and talk to a lot of patients about ways to kind of promote non-supine sleep to help with OSA. And that's can work wonderfully, especially for people with more mild OSAs.
We used to always talk about tennis balls on the t-shirt. Are we still recommending that as a way to stay on your side or stay upright a little bit?
Yeah, absolutely. I will talk to people about doing that as a nice quick fix. There's studies that show it doesn't work as well as some of the more, like some people will just sleep on the tennis ball. So if that doesn't work for people, there are many companies that make kind of glorified fanny packs that you can put on you put like a little vest on. There's companies that have these like essentially a box that you wear on a vest and the box is on your back. Some people will do like pregnancy pillows or body pillows. There are all sorts of ways to do. There are even devices that will like vibrate when you roll on your back to kind of wake you up. There's all sorts of ways to do this. And if patients are comfortable side sleeping, some cannot if they have spine issues or hip or shoulder issues. But if they are comfortable side sleeping, that is something that I recommend very regularly. And then I guess going to surgery, this patient unfortunately would not be fortunately or unfortunately would not be a candidate for hypoglossal nerve stimulator. But that's always something I think about, since we know, I mentioned that older women especially tend to probably have better results with that. So when I see older, especially postmenopausal women in my practice with OSA, that's something I'm kind of thinking about in the back of my head. Certainly we will try all the non-surgical stuff, but that's something that I'm thinking about. The current AHI criteria for that is 15 it was just recently expanded to 100 as the inclusion criteria for an Inspire implant. So at 8 would not be a candidate, but something to kind of think about for the future if things get worse or if she's not tolerating some of these non-surgical options.
So for your patient with the, let's say came in with, the AHI of 25 an hour, your ladder is the same though. And let's say they don't tolerate CPAP. Then what is your next step in the severe OSA candidate?
Yeah,
or severe OSA patient, not candidate.
It depends. I mean, the oral appliance, I will usually talk to them about. It's certainly going to work better in the mild to moderate range, which is like the 5 to 30. As the sleep apnea gets more and more severe, I'm a little more skeptical that the oral appliance is going to work. But if patients are up for it and don't have any contraindications to an oral appliance, I'm all for giving it a shot. And we talk a lot about multimodal treatment of OSA. So I tell folks if CPAP's not going to work, it is probably going to be a combination of things. So I don't want people expecting there's going to be one thing that's going to cure. So we'll talk about maybe some positional therapy, some weight loss, oral appliance. And so I will always talk, regardless of how severe their OSA is, I will always talk to them about some of these things. And we kind of talk about just chipping away at it with every little thing we try can decrease a little bit. And sometimes a combination of 3, 4, or 5 of these things can get them where they need to be. And we try all of this before surgery. Absolutely.
Yeah. Do you find that your women patients tolerate CPAP better than your male patients?
I would say it's probably about the same. And the studies on this completely vary, like a lot of studies on topics in sleep apnea. There's some studies that show women do better. Some studies show women do worse. Some studies that show it's the same. But I don't think that I have really noticed a huge difference. The one thing that's pretty clear in the studies is that women's symptoms, like quality of life symptoms, don't tend to improve as much when they're wearing CPAP, even if they're tolerating it, which is also interesting. We don't really know why. It's possible because they have some more comorbid insomnia, restless leg compared to men that cause continued disruption of their sleep even when their OSA is treated with CPAP. We don't exactly know why. So I think for that reason, they could maybe be a little more frustrated with CPAP if they're wearing it and not feeling a lot better. But I tend to notice that they seem to tolerate it about as well.
And then is weight loss like management or nutrition or those kinds of, is a weight clinic associated with your sleep apnea clinic?
We don't have, that would be wonderful. We have a great weight loss clinic at UCSF that I will occasionally send to people, but we probably could do a better job having more direct collaboration with them. So especially now with all the weight loss medications, I think it's almost more of a discussion with our patients than it even used to be. Weight loss is certainly something I talk to all patients about. And I think it's important to talk about it. I think a lot of people think they need to lose like 50 pounds to make a difference. But I will tell people it's often even like 5, 10 pounds that can make a big difference in snoring or sleep apnea. The studies show if you lose 10% of your body weight, your sleep apnea improves by like 25, 30%. So it's often that first, whatever that is, like 15 pounds or so, that can actually make a huge difference. And I think just telling people that is kind of a sigh of relief that could potentially be attainable. And now it's a totally different discussion with the way I have so many patients that were not great surgical candidates and struggling with all the non-surgical things. And now they're going on some of these new weight loss medications. And likely it will make a dramatic improvement in their OSA. And even if it doesn't totally cure it, they're probably going to be significantly better surgical candidates at that point. So I think this is a huge area. The other thing I will say about that is that women tend to not respond as much to weight loss as far as an improvement in their AHI compared to men. I think it is because men, again, carry more of their weight in the upper part of the body. And so weight loss is probably going to make more of a difference. And so women, when they lose weight, can still have a dramatic improvement. Don't get me wrong, but it might not be as dramatic as a man would.
In terms of sleep surgeries, you mentioned women have better outcomes with the hypoglossal nerve stimulator. What other sleep studies have you found that there may be a difference in outcomes or complications or recovery when it comes to men and women?
Again, there is just not much on this at all. I mean, really, we really dug through it when we were writing this chapter article a few months ago. So we know that they likely respond better, especially again, older women, likely respond better to hypoglossal nerve stimulation. We know on DICE, they have slightly different findings. There are studies, kind of national database claim studies that show in general, women just receive less surgery than men, even when accounting for differences in incidence and accounting for BMI, et cetera. Except potentially jaw surgery, which I found, I don't know why women might receive more jaw surgery, but we don't have any studies that I am aware of that show any varying success rates or that even look for any varying success rates based on sex for any of the other surgeries like soft tissue, palate, tongue-based surgery, or maxillomandibular advancement.
Have you anecdotally in your clinic noticed anything?
I've certainly noticed that they tend to do better with hypoglossal nerve stimulator, which is what we know, but I have not noticed a significant difference. But I will say I have not specifically looked at it, but just anecdotally, I have not noticed that they seem to respond differently from either complications or success rates when doing any orthognathic surgery or soft tissue surgery.
Yeah. In terms of, I'm kind of rewinding a little bit, we talked about some of the consequences, comorbidities from OSA, like coronary artery disease, hypertension. Have you noticed any outcomes on mental health, or have you found anything with, addressing OSA on mental health in women? Like when, you've worn the CPAP now continuously for 6 months, do you find that your patients are happier or have a better sense of mood or well-being?
Yeah, for sure. I mean, I would say just anecdotally, I see patients come to clinic all the time, just whether they had surgery or whether we were able to find a non-surgical option that works for them. The one thing I hear a lot is I'm dreaming now, which is so interesting, is I think these patients with severe OSA are not even really getting much REM sleep because their sleep is so fragmented. So they're not actually dreaming. So I hear that all the time. And often even just like a couple of weeks after surgery, people will come and say, I can't believe it. I'm dreaming. I feel so much better. And so that's so rewarding. So I certainly do notice that, whether it's a surgical treatment or non-surgical treatment that the patient has opted for.
Our discussion, started out with, this difference between men and women in terms of symptoms. We talked about, you mentioned underrepresented minorities in terms of access to care. Tell me a little bit in terms of, what are you seeing and how we can provide more equitable care?
Yeah, I mean, this has been and is a huge interest of mine. I wrote my trialogic thesis a few years ago on this topic. Oh, thank you. Yeah, that was a big hurdle.
That's a big
goal of mine. On just kind of barriers to care in general for sleep apnea surgery specifically. And I have continued to be interested in that. And now it's kind of coincidental that I spend a portion of my time at a safety net hospital where I see these things kind of firsthand. So there have been a few studies, not a lot in this area. And we actually just got an article accepted to the laryngoscope. So it should be out soon, it's a scoping review of some studies looking at barriers to CPAP alternatives. So not only is that surgery, but also mandibular advancement devices. And it also unsurprisingly seems that it is people that have higher income, better health literacy, kind of all the things that you would unfortunately expect for patients that get that far in the system. I think the problem is we talked about the delays in getting the sleep study and then getting CPAP and trying the different masks and then getting a referral for mandibular advancement device and then asking for a referral for surgery. And I think there are so many places in that flow to kind of get lost if you don't have great health literacy or are non-English speaking or are kind of underinsured or don't have the means to take off that many days of work. I mean, there's so many areas where people get lost. And there are studies that show that Black patients are less likely to undergo sleep surgery, that many of our underrepresented patients are more likely to be undiagnosed with OSA and probably have higher risks from OSA. And so this is a huge area that I think we're just kind of starting to delve into trying to figure out.
Yeah. And I bet the impact is even compounded for Black women if we're taking into consideration race and gender and how that sort of can make it even more difficult to get diagnosed.
I think about Black women all the time in that I think we all know and has been in the news a lot, the increased mortality rate around childbirth. And then I was thinking, couldn't help but think about this as I was looking at the studies on OSA during pregnancy and increased risk of mortality and increased complication for moms and babies, that I'm sure that's part of it. I have to believe, again, I don't know any studies that have specifically looked at this, but I have to believe that is a place we could do a better job.
Any recommendations on how, just in our practices, we can be a little bit more equitable when it comes to sleep apnea, whether it's with our female patients, our patients who are underrepresented minorities?
Yeah, I mean, I think one is just kind of acknowledging that it probably is a slightly different phenotype for women with OSA and realizing that they have these different symptoms, that we don't just either disregard them or assume that they're related to insomnia or, anxiety or depression or some of these other things women are more likely to get diagnosed. So I would say having a low threshold to get a sleep study if the patient hasn't already had that. And then improving our screening. Both we talked about pregnancy. I think certainly we can do a lot better job in screening and treating during pregnancy. But I think just in general for women, being more inclusive in the way that we grade sleep studies, in the way that we screen for OSA, just in general and in the perioperative period to better identify these patients. And I think for our underrepresented patients, there's so much more. That's why we just are kind of right now finishing a study where we're kind of just interviewing patients and seeing where are things falling apart? Where are you kind of getting lost in this flow, and even trying to identify where this is happening? But I think a lot of it is going to be education, community outreach, trying to kind of better educate these patients, the PCPs that treat them, and get more information out there so that they can get treated if they have OSA, because they deserve to get that identified, diagnosed, and treated appropriately.
That's cool. So y'all are doing qualitative studies when it comes to that.
Yeah, it's been really great. Yeah, we have an excellent medical student who's been with us a year that's been surveying and interviewing all our OSA patients at the Safety Net Hospital where I work at. And we've identified things that I would not have thought of as barriers, and then, of course, the next step to this is fixing that. And right now, we're now meeting with PCPs at our Safety Net Hospital to see what resources they have, because they're often the first people that are screening for this. And so that's kind of the next step in seeing what we can do to help at that level in any way identify and diagnose these patients.
Do your pulmonology colleagues and partners also kind of notice the same thing? And tell me about that partnership.
Yeah, we work very closely, both in my role at our Safety Net Hospital and at the main university. We work extremely closely with our sleep medicine and pulmonology colleagues. We review all these complicated patients who are struggling, and we're trying to figure out the best treatment for them. We'll do some multidisciplinary discussions, sometimes even in-person multidisciplinary clinics where we're seeing the patients together and really working with them on what is the best choice. These can be complicated decisions to make when patients have failed a lot of things and have, medical comorbidities. And so it's really necessary that this be a multidisciplinary discussion and evaluation.
One last question, in terms of the mandibular advancement devices, is that covered by insurance, or is that something that's out of pocket?
It depends. I will say that my experience is that a lot of the private dentists do not take insurance for these. I think because probably the amount of visits and cost involved with getting them made and getting them fitted. Although our dental school does bill insurance, that does not mean everyone gets it covered. For our patients that have state-funded insurance, this is not a covered benefit. I mean, that's something that I see at our Safety Net Hospital. There are not a lot of options for them. That, if they can't tolerate CPAP or we're stuck, they're not covered for hypoglossal nerve stimulator just across the board. They can't get maxillomandibular advancement. It's pretty much not doable with the costs involved with that, with orthodontic work that's required. That is pretty cost prohibitive for them, as are these mandibular advancement devices. So it brings up the other topic that we can really do a better job of treating these patients, because they unfortunately just do not even if they get diagnosed, they don't have all the treatment options available to them for many socioeconomic reasons that I am hoping I can help with all this research that we're doing.
Yeah, no, that's great. I've learned a ton, Megan. As we start to round it out, any final pearls that you want to leave us with?
Yeah, I would say my final pearls are just that I think there's so much more we can learn and we can do to help our women and our underrepresented minorities who have OSA, both from just identifying them to treating them and making sure they have the best outcomes to prevent the many complications associated with sleep apnea that we talked about. And so certainly, hopefully you could tell, is a topic of interest of mine, and I hope other people will be interested in this topic as well.
Thank you so much. If any of our listeners have any questions, are you on any social media? And if not, they can always reach out to us on BackTable, and we can always get the message to you.
Oh, yeah. I am on Instagram and Twitter, X. It's just Dr. Megan Durr. And don't have a whole lot posted yet, but my goal for the future is to start posting more on this as we talk about education. I think it is important to me to get this information out there. So more to come, but please feel free to follow me.
That sounds great. Well, thank you so much. It was wonderful to have you and to have this conversation. Thank you so much.
Thank you, Gopi.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, direct message us at _BackTable ENT on Instagram, LinkedIn, or Twitter. BackTable ENT is hosted by Gopi Shah
and Ashley Agan.
Our audio team is led by Kieran Gannon, with support from
Josh McWhirter,
Aaron Bowles, Nick Shellcross,
Josh Spencer.
Design and digital marketing led by Brian Schmitz, with support from
Taylor Spurgeon Hess.
Social media and PR by Chi Ding.
Administrative support provided by Jamila Kennebrew.
Thanks again for listening, and see you next week.